guess I'll get started since it looks like my talk begins at 9:45. This is a very free-form sort of topic, and was overwhelming when I was asked whether or not and how to approach this. So it's not very sort of research-based, but much more sort of updates in what we're able to do right now. But if you do have questions about which directions things are heading, please interrupt. I only have like 30 slides. I could probably get through them in 10 minutes. So there's a lot of time if you'd like to talk about other stuff. We do have some interesting things happening at Denver Health where I work. But yeah, actually just as a show of hands, how many people got a lot out of that opening talk? That was really, really cool. And one of the nice things about the Epilepsy Foundation and why I got involved with it back during my fellowship when I was working with Dr. Spitz, 2005 to 2007, is that it was really pretty obvious at the beginning. I was in about 6 months kind of trying to learn how to read EEG, learn how to manage really complex patients in clinic with him. But I discovered very quickly that, we do an okay job with seizures, but there's so much more to folks' lives than just the seizures they're dealing with. Now, of course, it impacts them greatly, but all the other things that we don't really touch well in clinic, really, we need help. And so the Epilepsy Foundation was the institution in the community that was really trying to address these other issues. So yeah, that was amazing, and I'm really proud to be involved with them and have been involved with them in many different respects since that 2007 time period. So if you are not already involved, please try to be. It's a wonderful institution. Okay, well, just a mile-high view of epilepsy and kind of where we are. You all know this stuff. Looks like from the look of the crowd, it's going to be kind of a very broad sort of experience level. So it's kind of hard to shoot a 20-minute talk at such a large target. So if I get too in the weeds, let me know. And I think based on who's here, I probably will be too in the weeds, or not enough in the weeds for some. So just, again, ask me questions. Then we'll just talk about diagnostic updates and therapeutic updates. I think new since the last 2-3 years, most of these things. I'm not sure if you're aware of what's happening. And, honestly, in our, buried and busy clinic, I'm not aware of all the other things going on too. So if you have questions about things you've heard or read, just shout out and ask about it. I think the entire group would like to hear. And one of the things actually I heard on NPR just a week ago. And so I sort of looked into it. I said, oh, that's neat. Never heard about that. So I included that in the talk. And as you know, epilepsy affects almost 1% of the population, and 1 in 10 people will have a single seizure in their lifetime. I saw somebody just like that in clinic the other day, and we were debating, oh my goodness, can you drive? Do we treat this? What kind of workup do we do? What are the things historically that might have contributed to your presentation? I was really trying to drill down because, it's so common. But the question for me is, does this person have epilepsy? Is this going to happen again? Is this person going to get in trouble? And that's what we sort of agonize over in clinic on this end of the spectrum. Honestly, a lot of the folks here in this room and in this conference are on the other side of the spectrum, not doing well and haven't been doing well. But the cumulative incidence of developing epilepsy is 2 to 3% over a person's lifetime, which translates to 65 million people worldwide. And 2.4 million new diagnoses each year. Epilepsy actually takes more lives each year than breast cancer in the United States. Fortunately, and I know I've given similar talks, and patients come up to me and say, no, that's actually not true. But statistically speaking, 2/3 of people, we can control their seizures with medications. Whether or not you feel fantastic, that's another story. Whether or not you want to take 19 pills a day, that's another story. But we can at least statistically understand that, 2/3 of folks who develop epilepsy, we can do a good job with regard to controlling their seizures with the meds. But that still leaves a whole third of folks, and that's where this sort of green chunk is kind of where people sort of bounce in and around epilepsy programs, and are really not doing well and struggling. Applying those statistics to Colorado's population, that means we are dealing with about 57,000 people with epilepsy, and 19,000 of them are refractory to medication. It's a ton. The good news is there are epilepsy programs popping up left and right all over the state. There are cynical reasons for this, but that's good news for patients with epilepsy. So with regard to diagnostic updates, when I was training back in school, we weren't really sort of thinking so much about gene testing, and autoimmunity and paraneoplastic syndromes were not a prominent feature of our initial thinking. Epilepsy gene panels now, I think this particular panel that I just got a screen cap on has 146 genes, and that's not even all of them. This one, you can add 35 more genes if you have a very specific a thought about a disease state. Now, what to do about them once we identify them is a little bit more tricky, but we do use them to confirm diagnosis. Oftentimes, coming to the end of a diagnostic journey is therapeutic also. It can help us predict the prognosis of patients who are having a tough time with their seizures, and more tricky, but we can also guide family reproductive counseling decisions too. The autoimmune epilepsy panels. So autoimmune epilepsy is something that's been evolving over the last 10 to 20 years, and now we're all thinking about it. But when I was training, we really weren't, and so. If you look in the textbooks, the older textbooks anyway, this is not something that's, widely talked about. But there are a lot of sort of stories in the media and news about, all of a sudden this just horrific, epilepsy coming from all over the brain. The brain is on fire, literally. And the classic symptom is less than 3 months of sort of a ferocious onset, medication-resistant epilepsy, coming with memory deficits, personality changes, psychiatric changes, tiredness, movement disorders sometimes, and even autonomic dysfunction, but it can also be as mild as just a single seizure at first. Obviously, they get worse very quickly, but at the very beginning, they're hard to see, and so we can test for some of these now. Paraneoplastic, that means sort of associated with cancer. There are also seizures, obviously, that can, through, we joking in medicine refer to evil humors because that was a state of medicine, back 200 years ago. But tumors can produce these evil humors that float around in your body and create havoc. Seizures can be one of them. Intracellular antigens, basically targets of these antibodies that are inside the cells, are very commonly associated with the seizures. And these are some of them. The anti-Hu, Yo, Ma, Ta antibodies have a greater than 80% association. So if you find one of these in somebody who you're suspecting has an autoimmune or paraneoplastic epilepsy, you better start hunting for the tumor that it's associated with. And oftentimes the epilepsy will sort of improve once you've identified and treated the tumor appropriately. Antibodies to neural surface antigens. So instead of the antibody target being on the inside of the cell, it's on the surface of the cell. These are not as commonly associated with cancer, but they fortunately also respond much better to immune therapy. So if we pick up a AMPA receptor or NMDA receptor or LGI1 receptor antibody, they actually do respond fairly well. So updates in terms of treatment options. Epilepsy is a field that's got so much hope in it because we can do so many things. Medications, surgeries, now neuromodulation, and complementary and alternative therapies are all strategies that we have to address epilepsy. And so the fields, each and individually within them, are moving on their own. And so when I got into medicine, I was looking for a field that was going to sort of last the extent of my career. And so pulmonary, cardiology, all of these things, physiology was very well worked out, but neurology was like, wow, that's something that we know so little about how to manage well. And over the course of 20, 30 years, I think we'll have some super exciting things. And then I got into it, and Gosh, a lot of these diagnoses are really depressing. ALS, Alzheimer's, things like that. But epilepsy was one that I was sitting in clinic with Dr. Spitz as a junior and met a patient that he had taken epilepsy surgery, and this is a guy who was afraid to leave his house and walk his dog because every time he had a seizure out in public, his dog ran away. To now totally driving, going to school, and having a normal, productive life. And so I thought, wow, this is a really, really cool field. And I would say there have been ups and downs over the course, of epilepsy management since 2007. But we're on the opening of another door of really exciting times. There are lots of medications coming down the road. There was a big drought that I think the CBD story opened up a little bit, but now we're about to sort of, we're on the precipice of a lot of great things happening. So much so that you really can't keep up anymore. Epilepsy and neurology in general is now thought of as more of a specialty of subspecialties, and epilepsy is such a complex field in and of itself. To stay on top of it is a 5 full-time jobs, if you will. So like I said, if you've heard something or have a question about something that I don't touch on, shout out, because I can't know everything, even though a lot of people think we all do. So anyway, these are some of the newer medications. So this is our traditional sort of armamentarium strategy. It's like, oh, you've got seizures, let's try med, okay? We've got gobs of meds, and these are some of the newer options. Brivaracetam, cannabidiol, obviously. I think a lot of people were expecting me to talk about this, but I wasn't asked to, so that's okay. But you can ask me anything. Stiripentol, Afinitor, cenobamate, and this one's kind of an interesting sort of scenario. So Briviact was approved for adjunctive therapy for partial onset seizures in in people over 16 years old. And there are 3 main pivotal trials, including almost 1,600 patients. These are very refractory patient populations. They're having 9 seizures per month, and their trial reductions of 16% in the 7-day frequency compared with placebo versus the 25% reduction in 1 month frequency compared with placebo was ultimately what pushed the FDA over the edge and approved this. Side effects include drowsiness, dizziness, fatigue, pretty typical anti-seizure medicine stuff. And the serious adverse events are, again, pretty typical as a sort of a blanket warning, not super common. I mean, you'll hear about a onesie, twosie kind of story about suicide thoughts and thoughts of dying. But really, mood irritability is a much more common sort of presentation for some of the psychiatric disturbances as a blanket statement across all of these medications. Cannabidiol, obviously that's been a very long and interesting sort of road in the last 5-6 years, in Colorado specifically. And again, I can answer any questions you have, but Epidiolex was eventually approved and has been available for about a year, a little over a year now, for Lennox-Gastaut syndrome and Dravet syndrome in kids over 2 years old and older. The Lennox-Gastaut improvement was a 43% drop in seizure frequency compared to 20% versus placebo, and Dravet was a 39% drop in seizure frequency compared to 13% placebo, and this is what tipped the FDA in favor of this. It was such good data, in fact, they actually gave it a primary indication, which most modern medications are added to an existing therapy, and then they have an adjunctive sort of indication. This actually achieved a monotherapy indication based on the strength of the data. Side effects include sleepiness, anorexia, diarrhea, rash. Most of these things, with the exception of diarrhea, I think of as probably comorbid complications with the existing medications as these patients typically are on, especially the sedation. It has a co-metabolism issue with valproate and clobazam, and so tends to make those levels relatively higher than you think you're getting. And so we often will sort of lower that dose if the patient starts to complain about sedation. In my patient population, though, I don't treat kids, I'm only treating adults. The volumes are much higher of the actual liquid, and so these are 4 and 5 mils twice a day of an oily-based product. And a lot of my patients report, at least initially, diarrhea, kind of loose stools, some GI upset, and that's what I see typically. Serious adverse events, again, the broad warning against suicide and thoughts of dying, of course, but the liver enzyme changes are something that we have to screen for. And so they make very specific recommendations about how to screen the liver function panel after initiation of these meds. Stiripentol is a fascinating drug. Again, I don't use it as an adult epileptologist, but they use it all day long here. It's also approved for Dravet syndrome and adjunctive therapy, usually in the concomitantly with clobazam and valproate, also in age over 2. The pivotal trial, number 1, had a 71% responder rate compared with 5% in placebo, which is phenomenal. I put it in quotes, and this is the reason why. The responder was defined as a 50% reduction in seizures in the second month compared with baseline seizure frequency. So not first month, not third month, just the second month. So the choosing of that very narrow window is a little bit interesting to me. But it was compelling, and the FDA approved it. And similar, very high response rate of 67% in Italy compared with 9% in placebo. Side effects include hypersomnia, anorexia, agitation, again, typical anti-seizure drug side effects. Afinitor is a very specific agent right now that we're using for tuberous sclerosis, if anyone has that or is treating folks with that. It's an mTOR inhibitor, and I believe they're actually looking for a larger indication in the future. Currently, it's only available for use in tuberous sclerosis. The pivotal trials involved 366 patients, and the percent reductions in seizure frequency were positive above placebo, 14%, at all of the doses tested. A low dose was 29% reduction, and high dose was almost a 40% reduction, which is pretty good. The side effects are pretty similar to this class of medication. Cenobamate is a medication that's coming out. I believe the submission to FDA has already been made. It has not been formally approved yet, but I think is imminent. Its mechanism of action is thought to enhance GABA receptor modulation and decrease sodium channel currents, which is a nice combo pill, if you will. Sodium channel modulation is what we typically think of when we think of Tegretol, Trileptal, Lamictal, and even Vimpat. And then if you actually throw GABA modulation, it's like throwing a benzo on top of that. And so that's a combination that we would probably use anyway, all in a single pill, which is pretty cool. And if you look at the data, it feels like a synergistic relationship between these two mechanisms. In their 1,900 patients in their pivotal trials, a median seizure frequency decreases were seen at all doses. So if you look at placebo, that was at 24%. The low dose was 35%. The 200, the medium dose was over 50%, and the 400 was very similar. The most impressive part of it, though, was in the convulsive seizure response. At that medium dose of 200 milligrams per day, there was a decrease of 91% of convulsive seizures in this study, in these series of studies. Side effects are pretty similar to typical drugs. Serious adverse events, I think it's important to note there were some drug reaction with eosinophilic and systemic symptoms cases reported early. But that was only seen, I think it was kind of a tight cluster in the very early part of the study and not seen toward the end of the study. So I think that needs to be ferreted out, and I think that's probably what the FDA is struggling with, but my understanding is that it's probably avoidable with a slower titration to reduce that risk. But cenobamate, if you look at the generic name, is similar sounding to felbamate, and I think they share some chemical structure together. So this is not approved for fires or febrile infection-related epilepsy syndrome, but there are these cases of minor illness, then resulting in this just horrific status epilepticus that just won't be broken by anything. That's the NORS, the new onset refractory status epilepticus. We see these on occasion, and we think it may be related to this overwhelming inflammatory reaction. And so there was a thought that if we can break that inflammatory reaction with a medication, that might actually help the status itself, and then the cognitive outcomes down the road if the patient survives. So they looked at a lot of different agents, but this agent here, anakinra, which was actually approved in 2001 for rheumatoid arthritis, has actually been used quite a few times. I think a large handful, or maybe 2 handfuls of cases between the University and Children's Hospital. We did have a case at Denver Health, I think, that we eventually shipped to Children's Hospital and received the same treatment. And my understanding is that it was pretty dramatic. It is a slow sort of response time, about week 2, but compared to the treatment regimen that the patients had received prior to that time, I think it was strongly felt that it was related to this initiation and not just, burning out. All that's controversial if anyone at Children's has a thought about that. So, updates in therapy. What are we able to do now? Again, when I was training, the thought of, a laser sort of doing epilepsy surgery was being talked about, not sort of in the middle of the United States, but it was, being used for other parts of neurosurgery. Now, it's basically standard of care, something that I never would have thought of back in 2005. And this is the article, the strokes and hemimegalencephaly, that the radio article that I heard the other day, literally I think 2 Fridays ago on NPR. It's pretty interesting. So laser interstitial thermal therapy is essentially stereotactically guided and placed heat probe that we put into what we think of and have identified as the person's epilepsy seizure onset zone, something that we want to destroy. Hopefully there's a lesion, hopefully there's something that we can see on MRI or some sort of other imaging modality that we can blame and have proven seizures are coming from. So this thing has essentially millimeter precision in terms of the stereotactic placement. The patient is then moved to the MRI suite, and then the laser is turned on as the MRI is going, so we can see the extent of the heat lesion. And it can be sort of advanced, pulled back. Different trajectories can be provided with different laser probes. Each pass is fairly expensive, and so we try to do everything under one single pass. But there are institutions around the country that are doing 3 and 4 and 5 passes, depending on the case, of course. Compared with traditional open craniotomy, this is sort of the curative epilepsy surgery that most neurology residents who become epilepsy fellows are super excited about because, there's not a lot in neurology that we actually can cure, but this is one of them. The standard anterior temporal lobectomy as compared to the laser therapy, seizure-free outcomes are very similar, 53 to 80%. And I typically quote somewhere in the middle here, depending on the type of lesion that we're seeing. There are far shorter hospital stays. Basically, once we've identified through intracranial EEG monitoring where the seizure is coming from, we then sort of remove the electrode, send the person home, let everything heal up, and then bring them back for this procedure. They basically come in, have the frame placed, imaging, and then the MRI treatment, and then everything's removed, and they can go home that day or the next day, or if some complication happens the day after that. As opposed to the old school temporal lobectomy, where a large skin flap is made, bone window is made, saved sterilely, large resection is accomplished, put the bone window back, sew up the skin, then you go to the ICU for a day, and then you sort of convalesce in the hospital for another week while we're managing pain and swelling and just not feeling great after brain surgery, because it's brain surgery. So yeah, it's a huge advantage. For me as a neurologist and an epileptologist, the outcomes from the cognitive deficits are, I think, the most compelling piece of this. Because in truth, in the anterior temporal lobectomy, what we're really trying to get at is something called the hippocampus in general. And it's hiding behind some normal tissue. So the standard en bloc surgery means we have to sacrifice that normal tissue to get at the bad tissue. And so with the laser interstitial thermal therapy, we don't have to do that. We can actually put the laser probe into the tissue that we want to destroy, leaving all that other good stuff, okay? Now, if the seizures aren't resolved, if they come back, we can always go back and do it again, or we can, we haven't taken the en bloc surgery off the table either, so we can always go back and do that. And so I think less is more up front, and I think because the seizure-free outcomes are close enough, it's something that I think most folks are being offered up front now. You have a question?
Yeah, not related to this.
Uh-huh.
I am curious about if there are any studies out or studies that have been done about menopause and epilepsy, and if there's any correlation to there. And I'm curious about that because I've had epilepsy since I was 7, and then it went away as an adult, and coincidentally it came back with a vengeance around the time I went in.
Yeah. We definitely have been observing hormonal-related exacerbation of epilepsy forever. Whether or not it was acknowledged by the general neurology community, I would say probably not until more recently, probably the last 10 to 20 years. But if you talk to an epilepsy specialist, trained beyond just a general neurology residency, this idea of a catamenial pattern or a seizure pattern following your period is super common. It's not even a surprise anymore. It used to be a long time ago, sort of poo-pooed as she's just crazy. So that's not the case within our community. However, what I would say is your experience is uncommon in that most of the times we see the seizures worsen with the onset of the reproductive period, and then get better as the person reaches and then enters menopause. But that said, everyone's an individual, and everyone's sensitivity to estrogen and the lack of estrogen is something to pay attention to. I think it's harder to know. We can talk about it sort of, now or offline, depending on how open you want to be about it. But all the hormones floating around can also have issues with other medications that you're having too. And the sleep is a factor. And so if you're not sleeping well, now that could actually be the problem, and not so much the timing of the estrogen, the lack of estrogen. It's a complicated thing. The report is acknowledged. We've seen it. We know about it. It is on the rare side. But yeah, I think we just need to, whoever ends up treating you needs to sort of, hunt as to other comorbid sort of complications that might truly be exacerbating the seizures, and the timing is such that the menopause has been entered. Does that make sense? Okay. So visual ACE, this is the initial laser interstitial thermal therapy approved in the U.S., was so actually in 2007, which was surprising to me because we weren't really talking about it in Colorado that much. Neuroblate came shortly behind in 2009, but they had an issue with some of the metallic thermocouple, and I think it was eventually fixed last year, and so I'm not entirely sure where things are with regard to pluses and minuses. I do know the visual ACE probe allows the surgeon to predict the thermal injury at the tip of the probe, and the neuroblate actually is directional. It shoots out of the side, and so I think it's the potential advantage there is you can hit things that are sort of off the primary axis, which I think is actually an advantage if you think about the neuroanatomy. This is probably for like 3 people in the room, but you can hit the hippocampus and amygdala at the same time. I think it's become U.S.-wide more widespread standard of care, even later than this 2012, 2013 time period, but we were beginning to explore that here in Colorado then. So this is that story on NPR that I thought was pretty interesting. Hemimegalencephaly is not something we typically see in adulthood or not previously diagnosed in childhood. It's a rare condition. Yep.
I just have a quick question
Yeah.
back to the laser.
Yeah.
Is that primarily for a known, like a tumor so for instance, like a focal cortical dysplasia?
Yeah.
You have an idea that
Yeah.
you can't visualize the neurons that you are suspecting that this patient might have. Is it more for a growth or
Yeah.
something that's obvious?
Yeah, I mean, the reason we quote these ranges, 53 to 80%, is if you've got something that we can see, you end up over here. If you have something that we can't see, you end up closer over here. Okay. It's still better than meds, and ultimately still better than neuromodulation, at least in the first year or two. Okay. It looks like the long-term data, which I'll share later, is really encouraging for some neuromodulation options. But yeah, if you electrographically identify a seizure focus, but there's no anatomic disturbance there that you can hang your hat on, your seizure-free rates drop a little bit, actually quite a bit. Yeah, so if you talk to an epileptologist, yes, I want to see a cortical migration defect, I want to see mesial temporal sclerosis, I want to see scarring from an old stroke or tumor, that'd be great. If I don't, I'm thinking, yeah, we should still do it anyway because it's still better than meds, but yeah. Okay. I'm sorry, what was the last part?
Malformations, it's been used with that.
Yeah. Are you telling me or asking me?
Is that correct?
Oh, yes, I think that's right. I'm not a surgeon, but yes, it was actually approved for, I think, soft tumors well before we started using it for epilepsy. But yes. You have a question?
I just wanted to add something to the question that was asked earlier. In localizing a lesion related to epilepsy, there's also other modalities that's available, such as get-to-it, SPECT, PET scans that can help to isolate exactly where the seizure is originating from. Not necessarily just to look for a structural abnormality, but to look for a focus of where the seizure is coming from to consider laser therapy.
Yes, that's right. We do use all the non-invasive means available to us. Again, when I reviewed my own personal data at Denver Health, PET-positive lesions of mesial temporal sclerosis actually, unfortunately, didn't do quite as well as MRI-positive ones. And so while these anatomic non-invasive imaging studies offer useful information, I still think, the slam dunk cases are still do better. Okay, will we go forward with a PET lesion, a nictal spec lesion, a MEG lesion, all these things that if you have questions I can sort of clarify. But yes, we'll use all of that because we want ultimately to cure that person's epilepsy if we can. We have to temper it by the fact that, what are the risks, what are the benefits, is a 25% likelihood of seizure-free outcome good enough? It might be for one person, it might not be for another person. It's a very tailored sort of conversation, but we try to get as much useful non-invasive data as possible because, for all intents and purposes, non-invasive is safer. Okay, by the time we start poking the person, then we increase the risk of the workup in addition to the actual surgical evaluation, therapy. Yes? Yeah, so again,
If they're going to be asking questions,
Yeah.
this is for if we're recording.
Okay.
we need to-
okay. Oh, okay. So the question was whether or not the laser can be useful for things like Lennox-Gastaut. That's a complicated question. Let me go backwards and sort of simplify it from the beginning. We use a destructive therapeutic option like open surgery or laser surgery or radiofrequency ablation, things like that, if we have a very specific focal lesion, okay? And so when we don't have a focal lesion or we have too many foci or we have something that's generalized, whatever that means, we don't offer these kinds of therapies because they don't work. Epilepsy we think of as a network abnormality, and so if the network is too broad, you can't destroy any specific area in it to have the effect that you want. Okay, yeah.
Okay. Is it? What are the primary risks associated with the laser therapy?
Again, they're the same as any sort of destructive option. If you, anytime you break the skin, infection is a risk. The heat lesion itself, if it's too close to certain structures, you can cause injury to those structures if you're not careful, or the guidance system is off, or the MRI is not giving you useful, accurate data. You can cause injury to tissues that you don't want to injure. And then the insertion of the probe itself can transect blood vessels that we try to see. We actually do contrasted studies and use computer imaging to merge those things so we can pick a trajectory to avoid all those things. But there are smaller vessels that you can't see. And sometimes there are problems with computers that, the fusion is off. If you're off by 1 millimeter here, off by 2 millimeters there, off by 3 centimeters, you can be too far to the left, too far to the right, or too far forward. And so there are always those kinds of risks. Now, the risks are small. In the old days, the stereotactic needle electrodes carried about a 1% per electrode risk. We're not seeing that. It's way smaller than that now. I would say the entire process, 6, 8, 10, 15, 20 electrodes are still carry about that 1 to 3% risk. But again, the community doesn't have the pooled experience to be confident to say, yes, this is this is that risk. Again, there have been bad outcomes. Okay, there have been bad outcomes, but it's not something that we see commonly enough to not do this anymore. Okay. Should I move on? Do you have any more questions? Okay. Anyway, the radio story from last week was about a girl who had Hemimegalencephaly, which is a rare condition in which half of the brain is abnormally larger than the other and is associated with frequent seizures, cognitive and behavioral disabilities. Seizures present as infantile spasms, often greater than 50 per day, and are very resistant to medications. The traditional treatment is surgical removal of an entire hemisphere or the functional disconnection of the abnormal hemisphere from the normal side. That's sort of literally putting a little a knife blade through, if you will, each half of the brain. The hope is that the normal side takes over both hemisphere functions over time, and if it happens in 1, 2, 3, 4 years of life, the functional recoveries are unbelievably good. This is the toddler that they talked about, 10/25/2019 in People magazine. I found that article. I couldn't find a medical literature sort of account of this. I don't think it's been published yet. They're fairly busy. But toddler thriving after a doctor cures her by inducing strokes in her brain. And what they did, Children's National, this is in Washington, D.C., under this doctor, Dr. Tae-Eun Chang, used a microcatheter and basically injected glue into several different blood vessels. This was 3 separate procedures over 4 weeks' time, and did a functional, hemispherectomy by sort of destroying that hemisphere by stroking it. The report in October was that at 14 months old, she's down to 3 seizure drugs. She's now able to talk, as a 14-month-old can, reach for things, and her adoptive mother reported that she has had no seizures since the original procedure at 1 month old. Again, case report, very interesting. Just heard it, a week and a half ago, 2 weeks. But this is the way the field is. We have a lot of great minds thinking about it. We want to bring hope to a lot of folks, And sometimes they're doing some unconventional things to affect that change. So in terms of other therapeutic updates, neuromodulation has become incredibly explosive in terms of its developments in the last couple of years. VNS, which has been around a long time, just came out with a new model in 2017. This is the model 1000, or the SenTiva. It's smaller in design compared to the old 102, which we were using a lot way back in the day. This is similar in size to the 105, but it has a better battery compared to that, and the auto-stimulation function is similar to the most recent iteration, the model 106. New to the 1000 is that it has scheduled programming, guided programming, and day and night programming. A lot of folks don't like the fact that it's going off all day long, or they work in a situation where they don't want their voice to change, and so they want more aggressive treatment at night when they're sleeping and less aggressive when they're daytime. Or if you have somebody, in terms of scheduled programming, lives on the Western Slope, they don't want to trek into Denver, every 2 weeks while we do this ramp up, we can actually pre-program the ramping schedule, and so they don't have to keep making that trip. And then you can also choose, anyway, that's essentially the main difference. It's a huge patient satisfier with regard to the new model. You have a question?
I understand this to be adjunct therapy with medication. Is there any chance that it won't be down the road? Like medications would be more controllable and less, and this would be better. And I'm just asking because I just had a baby, so I'm just curious about this.
Yeah, it's not something that I would predict, but it's something that we see. So, again, I think of the addition of this as, okay, I've got a patient with medication refractory epilepsy. For whatever reason, they are not a good candidate for epilepsy surgery at this time. This is a very sound sort of option. And if we add it and the person's seizure stop, then we can start backing off their meds. If we add it and the seizures improve, then, then it's a little less clear what to do. Do we go up higher in the VNS? Do we tweak the medications? It depends on side effects. It depends on a lot of different factors. Yeah. That's why you just need to see your doctor. Okay. Yeah. Yeah.
Are you getting closer at all to kind of seeing what the settings are more geared? Because with my son, we constantly go up and down. Sometimes when we increase, they get worse. Is it getting closer to where there's a general setting that seems to help people?
Unfortunately, no. We know more is better in general. Just as a matter of course for medicine. If we have a mechanism that's working, if a little works, usually we think a little bit more works also. Is there a sweet spot? It really depends on the person, if it's going to work at all, and that's why you see a lot of sort of tweaking around the edges.
Sorry, back to Epidiolex.
Yep.
Epidiolex as well, are you guys getting closer to kind of seeing a general dosage that's working for CBD? Because with Charlotte's Web, the dosages were a lot lower, and then how they're seeing, with Epidiolex, it's recommended much higher. Some kids doing better with THC. Is that making any advancements, kind of finding those?
Yeah, I am not aware of anyone doing that head-to-head study, which I would be super fascinated by. Again, it's controversial. There's this concept of full spectrum, whole plant, you needing all of the other phytocannabinoids in addition to the CBD. Obviously, with regard to FDA and pharmaceutical production in general, we can't deal with that degree of variability. And so isolated compounds have a tremendous advantage in that you can test it more easily and more efficiently and more confidently. It's interesting. The folks at GW, when they were looking for designing their drug trials, actually came to Colorado to see what was happening. And so their low dose was roughly what Charlotte Figge was taking. I think I did the calculation. It was like between 8 and 9 milligrams per kilogram per day, where her sweet spot was reportedly. Okay. Her mom was doing, milligrams per pound calculations, and so I had to, do the math. But I think it really, just like everything in epilepsy, things work, things don't work, and things break down, and we don't know why. And so it's a constant conversation. You see a doctor, you complain about an issue, we try to figure out, is it med-related, is it seizure-related, is it, something else happening? And then we make adjustments going from there. And I know it's very frustrating, but it's yeah. With regard to its efficacy updates, the VNS had some data in March of this year. 53% of patients had a greater than 50% reduction in long-term follow-up. And predictors of success include shorter duration of epilepsy rather than younger age of onset and implantation, which is a little bit counterintuitive, but at the same time, it also suggests that maybe this is a person who in years past would have tried more medications sooner. And this is just, it works, and we just offered it sooner to this person or this group of people, and it had a better effect. Deep brain stimulation, something that we sort of have adopted from our Parkinson's folks, our movement disorder people, was approved for focal seizures resistant to greater than 3 medications in patients over 18. This was approved in 2018 in April. The first implant was in Colorado this year. I believe Dr. Ogeman did that. Someone might clarify. The pivotal trials were interesting. 40% responded to DBS compared with only a 15% responder rate in the placebo group during the 3-month follow-up. And 75% seizure reduction was seen in long-term follow-up. And we're seeing that, and we've seen that from VNS and now DBS and now RNS, that the longer these devices are in, which is why we're calling them not neurostimulation but neuromodulation, they seem to get better in that person. Serious events are all really related to the implantation itself, intracranial hemorrhage, cerebral infection. The one that we worry about actually comes from the DBS and movement disorder literature, but also has dribbled over to the epilepsy literature, but the psychiatric complications, anxiety, depression, apathy, mania, cognitive impairment, and then this, again, increased incidence of suicide. This was an interesting article that I found, what year was this, 2018, Finding the Sweet Spot. So in VNS, it's kind of funny. During the standard titration, when people would hit 0.75, we'd all of a sudden, very commonly, see the person's seizures get worse, even if they had responded earlier. And then once we moved past 0.75, they actually got better again. And so there are a lot of theories about why that happens, if that even happens. It's a kind of a controversial thing. But it turns out it may be that the psychiatric disturbances associated with DBS might also have a sweet spot too. It might be that if you can talk the patient into moving through that as you continue to adjust it, that it goes away as well. In this study, 2 of 22 patients with DBS for epilepsy developed paranoia and anxiety. And again, it's not a big number, 10%, but it later resolved after the parameters were changed. And so this is an evolving sort of thing that we need to look at. A lot of times when we are in epilepsy surgery conference, if somebody has a strong family history or a personal history of psychiatric disease, we're like, I don't know. This may suggest that that's not always, the right way to approach the patient. So in RNS, approved for adjunctive treatment for focal seizures greater than 18. This happened in November 2013, and first implant in Colorado, December 2015. Pivotal trials involved 31 sites around the U.S. and demonstrated a 29% reduction of seizures compared with 14% placebo. That doesn't sound super awesome, but if you look at this update from May of this year, at 9 years, 1 in 3 people achieved a 90% or greater seizure frequency reduction. That is phenomenal. This was in the 256 patients previously identified at enrollment who were having 10 seizures per month just to get into the study. So this is huge, and so that's obviously very encouraging for persons with epilepsy and the folks who treat them. Okay. Do you have any other questions that we haven't covered? Go ahead.
As it pertains to the RNS, could you explain a little bit more about the leads? Is it just 2 leads that activate, but you implant more than 2 leads? How does the RNS functionality?
That's actually a complicated answer. The short answer is it can stimulate 2 at one time. On the horizon, the very near horizon, is the ability to record and stimulate from 4. Okay. So the questions we're asking ourselves right now, since we know this is off in the future, do we go ahead and implant a bunch and then wait for that new computer to come out and then swap it out? Who's going to want to do that surgery, patient-wise? Who's going to want to pay for it, insurance-wise? That's not as clear. So we're right in the middle of this transition situation where it's a little murky. That said, it does offer, through our phase 2 testing, through our intracranial monitoring, if we identify 2, 3 foci, we would want to treat them. And so right now, the question is, do we cover all of the potential nodes of this network, or do we go after the more aggressive ones? Because one of the values of this thing that I didn't understand as a fellow is that it's essentially like it's an indwelling ambulatory intracranial EEG. This thing's sitting on, identified seizure-y brain. And so over the next year, 2, 3, 4, 5 years, we're collecting all this information being saved up in the cloud. And so we can sort of do this large, metadata analysis on a per patient basis to identify whether or not, hey, this is actually a super hot focus. We can actually go back in and ablate it. We can go in and cut it out. Or do we need to move our electrodes around a little bit to fine tune this thing? That may be the explanation why, the long-term response rates are so high, is because we have all this useful data we're recording. Do you know the fundamentals of the RNS? I mean, basically, once we identify where a seizure is starting or we suspect through phase 2 testing, we actually will put a RNS electrode into that area, whether it be a depth electrode or a paddle, a subdural electrode, and then it just records. And then for a period of time, we're teaching the computer to identify the person's seizure characteristic, their specific unique characteristic, and then we then turn on the treatment mode, and then the computer can then deliver a stimulation to try to shock that seizure from continuing every time it sees it. And so, this is a fun and exciting time from a surgical perspective. I know that's not palatable to a lot of folks, but from an epileptologist side, this is super, super exciting.
And then just back to the VNS, is it, once you have a VNS, are we, all the new ones compatible with the old wiring?
Yeah, so there was a huge transition problem from the 102 to the 106. There was something, the old wire that wrapped around the vagus nerve went through a 2-pin connection to the old models. They've now since adopted all the new devices have a single pin. And so in the folks that are sort of nearing the end of life on a 102, these conversations are hard. Do we want to risk injury to the vagus nerve to have a surgeon pick it off and then put the new one on, or do we just cut it and go around it if there's room, or do we just not? I think creating a dual pin to single pin connection would be great, but the amount of R&D involved in doing that for what is probably an issue for the next 5 years only is unfortunately doesn't make mathematical sense. Okay. But yes, moving forward, this is not an issue. All of the stuff is backwards and forwards compatible.
Hi. Follow up on the VNS question on the lead. If there's a lead that's in place for many years, say it was implanted when an individual was a smaller child,
Yep.
and now they've grown and developed into a young adult, any issues with that individual's development growth that lead might have any impact on down the road?
Yeah, it should not. They actually throw in a lot of extra loops. So as the body grows, it doesn't sort of tug on that stuff. But it can be redone if need be. More concerningly is not the length of, or the distance from the electrode to the can, but the size of the coil that wrapped the vagus nerve in the first place. Sometimes if they use too small of a coil because the kid was small, as they get bigger, it'll pinch on it. And so we've seen some complications like that in super long-term follow-up that we then, agonize over. Do we risk, injury by doing nothing or injury by trying to pull it off and then redo it? Then it depends, how well is the person doing on this device? Are they doing great? Okay, we should ask that question. If they're not doing great, maybe we just cut it and leave it. Okay. Again, it's personal. Yeah.
Dr. Mo,
Yes.
if we can take maybe just one more question and wrap up.
Okay.
Sorry, so I was wondering if you could just kind of explain if there's any success seen in biofeedback treatment, and then also if you could touch upon where stem cell treatment is at.
Yeah, I really can't for either of those. Dr. Fry, I don't know if she's giving a talk today. That's sort of her wheelhouse in terms of neuromodulation. Neurofeedback. My understanding is that it's a wonderful adjunct to traditional therapy. Is it useful in monotherapy? I don't know that anyone knows that or probably believes that's true. Okay. Stem cell, I don't. Yeah, I'm sorry, I can't speak to that at all. Yeah. Is anyone in the community investigating that? I don't know. Yeah.
Well, you hear a lot of advancements in other countries.
Yeah.
There's animal research going on. Yeah, as a vet tech, we were doing stem cell
Yeah.
10 plus years ago.
Yeah.
It's just, those fields.
Okay. Well, thank you very much.